Good morning. So I get asked a lot by the members of our practice and people in the community about when to send people to Oculoplastics for common things that we're going to talk about today. So I've kind of framed this talk as curbside consults, basically. So hey, I've got this patient with so-and-so. No disclosures. And so we're going to talk front-loaded with thyroid eye disease stuff. That's kind of a hot topic right now. And then we're going to go more into skin cancer. I do a lot of Mohs reconstructions and work closely with our dermatologists here in the community. So that's kind of a niche part of my practice that I really enjoy. And then a few other little potpourri things that I just thought were good to kind of fill out the time. So, hey, I've got this patient with thyroid disease and eye symptoms. What do I do with them? So the first thing I always talk to people about, especially when they're in the chair in front of me, is to remind them, they're often confused. They see all these commercials, they've heard about Tepezza or something, and they've got questions. And I always like to take a step back and just remind them, thyroid eye disease is not really a thyroid problem. It's an autoimmune condition. And so that's also important for us as ophthalmologists to remember, is that it's not always about the thyroid labs. So they may come to you with a list of labs on their phone now with their EMR on there and say, they're saying I've got thyroid eye disease, but my thyroid labs have been normal for so long. Well, it doesn't necessarily matter. We want to keep those under control because it does influence the symptoms they have, but that's not the only factor. And so, you guys know a lot of this, but dry eye, obviously every thyroid patient, even if they don't have thyroid eye disease, they're going to have dry eye. Most patients who don't have thyroid disease are going to have dry eye. And then, the other common things that we look for, of course, vision loss is becoming less and less of a problem as we start to get these better treatments and it's being recognized more widely. And then I also take time and actually draw this Rundle's curve out for patients to kind of explain to them sort of, my first thyroid talk, my techs hate it because I spend a solid 15 minutes just sitting down and talking to people after I've examined them, because it's really important to educate people. And I'm going to keep saying that about all these conditions. You got to take that time to help people understand what they've got so they understand why you're approaching it the way you are. And so I always tell people, I'm seeing you for the first time today. I've got to see you a few times before I really decide what I'm going to do with you and how we're going to work together to control this, unless it's emergent. Obviously, that's a different thing. But I don't see that many people who are coming in losing vision in front of me. A lot of people have had thyroid disease and even some changes like mild retraction or proptosis for years, and they're stable, but they just want more answers about what's going on with their eyes. Or the referring general ophthalmologist just wants to know, hey, what do I need to do with this person? So I draw this curve out and I just say, most people in that active phase, that's only the first couple of years, and then they kind of fizzle out. But if you can treat during that time with certain modalities, it can help decrease the curve and hopefully make it so that at the end of the time when the disease is burned out, they've had very little change, so that hopefully surgery and things like that aren't even necessary. But that point is critical at the beginning to kind of lower that curve. But I also tell people, once you've had some changes, getting back to normal or the way things were exactly is kind of hard to achieve. Some of these changes, even with surgery, you can make things better, but I tell people if we start at time 0 and we're going up, we may get close, but it's hard to get back completely to normal with some of these changes. So when do you refer these people? Certainly if they're developing symptoms rapidly in the active phase, so that's like the people who you see the worst pictures of, not just the retraction, that's the one that scares you when you Google thyroid eye disease and you see the first picture that comes up and you've got that deer in the headlights look. But the people who look like something else, they look like preseptal cellulitis or something, they've got swollen red eyelids, pain, chemosis, that sort of thing, those are the people who I think really benefit from that really early aggressive treatment. But even the people with subtle changes, if you just follow these people over time, you can see some of these things progress, but you have to check. You have to measure their MRD1. You have to monitor their pressure. And remember, if you're checking pressure in the chair, they're looking up slightly. So if their pressure seems elevated, it could be because they're pulling against a swollen inferior rectus. And then I think if you're sending somebody to a plastics person, it's really helpful to have some of these labs drawn, especially if they don't have a diagnosis already, before we see them, because otherwise I'm going to see exactly what you saw, and I'm going to still have to draw the labs, and they're not going to have any more answers when they leave my clinic. So getting the basic TSH, free T4, T3 really doesn't get followed much by me or other ophthalmologists, I don't think. But the TSI, the TPO, and the anti-TSH receptor antibodies are really important, especially if there's a question about what this really is. Those can be really crucial to find out and confirm that. And then a CT, especially if they've got proptosis, I think that helps, especially if it's asymmetric proptosis and you're not sure it's thyroid. If you're looking for a mass or something, you can find that on a CT. But it's especially helpful, it's fast, it's usually easy, CTs are widely available, and you can see the muscles really well. It's not like you're trying to look for a soft tissue tumor necessarily, but if I'm thinking about doing like decompression or something, it's good to see the bones too. The European groups have gotten together and they put out these guidelines for how to classify and treat thyroid eye disease. And in fellowship, this is what we used a lot. And it's, for most mild stuff, it's just basically symptomatic management. And then, of course, sight-threatening goes on to immediate IV corticosteroids and surgery potentially. But it's that moderate to severe group that is where kind of the gray area is, and there's some, finesse and differing opinions about exactly what to do with that. Got to talk about smoking cessation. That's the #1 modifiable risk factor for people with thyroid eye disease. Even secondhand smoke can increase risk of changes. So always ask about that. Ask about, if they're sitting in the room, they're telling you they don't smoke, but you can smell it on the person who's with them. Just always mention, even secondhand smoke is dangerous, so you really have to limit exposure to that. Of course, treating dry eye. Selenium was studied and shown within the first 6 months of diagnosis to be helpful at reducing progression. It doesn't necessarily change their symptoms, so I tell them, you can either eat 2 Brazil nuts a day, or you can go get selenium off the shelf at the drugstore, and it may not make things a lot better, but it may help reduce the overall how bad things get ultimately. When they get to that moderate to severe stage, that's when you want to send them my way. And I usually don't start any medicated therapy above and beyond what's in the mild stage the first visit, unless, again, it's kind of edging towards the more severe or rapidly progressing sounding based on the referral note or what I'm seeing. I'll watch them because I want to get multiple points on that curve and kind of see, are they escalating, are they plateauing, are they de-escalating, where are they in the curve? But the gold standard is still considered steroids for treatment for moderate to severe. IV methylprednisolone, it's supposed to have less side effects, and I think I agree with that. Mycophenolate was another one that in the new recommendations from 2021 was added, and what that does is it decreases antibody production by B cells, it's anti-proliferative to both B and T cells, and it induces apoptosis of activated T cells and inhibits fibroblast proliferation. So I had to go look up all that last night. I did not have that memorized. And then sight-threatening, definitely steroids and possibly surgery. And this is everybody's going to have this like hard-to-read slide that shows all the mechanisms of actions of things. But everybody's heard about Tepezza. If you've not, there's somebody out there willing to talk to you about it. But teprotumumab is a monoclonal antibody to insulin-like growth factor 1. And what it does is it binds to this complex. I don't know if there's a pointer on here or not, but at the top of the, so this complex is the IGF-1 receptor and the TSH receptor. And when that gets activated by these other activated immune cells, that's what causes all the changes, the increased adipocytes, the transformation to a myofibroblast. It's going to cause some of these constrictions, glycosaminoglycans, all the stuff that makes the orbit get stiff and fat, basically. And even in chronic TED, that continues to happen to a certain degree. So that's why actually more recently Tepro has been, it was originally designed for, looked at in people with active TED who had proptosis and looking at proptosis reduction. But now it's being looked at in chronic or even in people who have maybe even failed one round and doing repeat treatments. It's 8 infusions, 1 every 3 weeks, so it's about a 24-week treatment period. And there are side effects, and the big one that everyone's hearing about now, no pun intended, is hearing loss. And that's real. I've had patients, several patients who have had issues with that. All the patients I've had have not had anything permanent happen. They've described it as either like a mild tinnitus or kind of like when you're going over, through the mountains or in an airplane and you get that pressure change that comes from some of the changes this can have on the eustachian tube. Everyone that's had it has had it go away, but I am routinely testing audiology in all these patients now before we start. The other most common thing that people complain about is muscle cramps during and right after the infusions, but those only last for the first 24 hours after each infusion. So I didn't put up all of the case presentation stuff on this slide. I've got some good pictures, but as I was reviewing the slides last night, I thought there were some good things to glean from the actual details in these cases. So the first person I'm going to show you was a 29-year-old Vietnamese female. She came to me with 1 month of bilateral upper lid swelling, double vision, blurred vision, and pain, had been just diagnosed with Graves' disease and started on methimazole 10 milligrams 3 times a day with her PCP, was waiting to get in to see endocrine. Vision was okay, uncorrected, it was 20/25 and 20/30, had a small abduction deficit on the left, pupils, pressures, Ishihara plates, which is another thing everyone should check on these thyroid patients, were all normal. She had mild to moderate fullness in her upper lids, soft orbit, little resistance, only 1 millimeter of lag ophthalmos, MRD1 was 4, and some mild SPK. And her tail was 21 and 23, right and left at a base of 105. One thing I want to just take a second to say is it's important to touch your patient, especially when they've got orbital stuff. I think in ophthalmology we don't think about everything so hands-off. We've got a microscope, we're sitting kind of far away from the patient. But in plastics, it's really important to feel. Our sense of touch is just as important as our sense of sight for some of these patients. So don't be afraid to have them close their eyes and push on the orbits a little bit to get a feel for how firm they are, because that can tell you a lot. We got labs, but unfortunately she was leaving the country for Vietnam for a few months, so I lost track of her for 3 months, and then she came back, and it doesn't really show up as well in this picture, but she had a lot of redness in her lids, and you can really appreciate the left eye. And that's where we got the most reduction of proptosis. This was after starting teprotumumab. Quick resolution of symptoms. After 6 infusions, she was almost back to what seemed to be a good baseline for her. And she did have a little leg cramps, no hearing changes. One other thing that's interesting in her being reproductive age, she did have amenorrhea. And as of the last exam, she still was having trouble with that. But that just reminds me to tell you, always ask these people before you think about starting, because it's usually young females is the most common, about reproductive, if they're using abstinence or some sort of other contraceptive method before they start. I think the side views show a better example of the changes there. So the next patient, quite a bit different. This is an 82-year-old white female, 1 month of progressive upper lid and lower lid, just on the left, swelling, redness, and pressure, no pain, had been on Pred Forte because the outside doctor thought she had allergies. You'll see from the picture that's clearly not allergies. Presented first to one of our optometrists. Her vision in the left eye was 2100 uncorrected compared to 2050 in the right. Pressure and fields were normal, just kind of had generalized restriction on motility on the left. And I don't have the radiographs here, unfortunately. I didn't have time to add those to the lecture, but when I looked at it, it just looked like diffuse inflammation. With retrospect, there was some extraocular muscle enlargement. But when you look at the pre-picture here, I thought this was lymphoma. because she kind of fit the bill as far as the age and everything, and it being so unilateral. And you can probably appreciate a little bit of the chemosis down here, but the fact that it was painless and looked like this I was thinking tumor. And so since there was just kind of generalized inflammation, I took her in for a biopsy of the lacrimal gland to get some tissue. When I got in there, the lacrimal gland looked totally normal. I took some of that, I took some of the orbital fat, I also sent it for IgG4. All the labs came back negative, but because everything looked so normal, I added on a bunch of other labs, and thyroid labs happened to be one of them. And this second picture is her after 2 treatments with Tepro. She went from a Hertel measurement of 22 on the left to 13, just with the medication. And at her most recent follow-up, which was about 2 weeks ago, it was 12, down from 10 millimeters of proptosis reduction on the left just with that medication. So it really is doing some great things. I've also seen it not do that much for people who aren't active. So I tend to only give it to people who are having active problems. I've taken care of some patients who have had, who have been started somewhere else, and I inherit them because they moved to Greenville or something, who had either, had been post-orbitotomy and had some decompressions, and just started to kind of see where they could get with it. And I've not been too impressed with people who've had chronic TED yet, but that's what they're continuing to investigate. So shifting gears out of the orbit onto the eyelids. Now, hey, I've got this patient with an odd bump on their eyelid. Skin cancer, super common, more common than I even realized. 9,500 people every day are diagnosed with skin cancer. 2 people die from skin cancer every hour. And 1 in 5 Americans will develop some sort of skin cancer by the time they're 70. So, and 85% of basal cells occur on the head and neck. I always go over patients, especially if there's a lesion I'm not quite sure, it doesn't have a lot of red flags, but I'm like, let's just watch this for a few months. Always go over the ABCDs with them, asymmetry, border irregularity, color, diameter, and then evolution. Is it changing over time? And really just have a low threshold for biopsy. If you're not sure, I mean, a biopsy for most of these things is relatively simple, and I don't hesitate to do that if I'm not sure. There are several things that can look like skin cancers that aren't, that can really throw you off. One thing's sebaceous hyperplasia. It's not showing up too much on the projection as well, but these look just like basal cells. And if they have a lot of them, you kind of feel comfortable saying, this is probably just sebaceous hyperplasia. If they just have like this one and it's like right here, not too sure, because you have a central pit, you've got telangiectasia, it's got raised pearly edges. It's hard to delineate, so if you're ever not sure, just biopsy it and know for sure. But it can look just like that typical basal cell you see on the other side. Squamous cell can look like a lot of different things. I've been so sure something was a basal cell, it was a squamous cell. It can mimic really bad blepharitis. Things to look out for here, lash loss. You're typically not going to see that with blepharitis unless it's been going on a really long time and it's really bad. But so like in this person, no lashes here. Architectural changes too is a red flag. So if you start to see notching or scar tissue and no history of trauma, that's a time to go biopsy. Melanoma, thankfully I don't see a lot of it, but you can confuse that easily with like a really dark pigmented seborrheic keratosis or a solar lentigo. Most of those things though are pretty regular looking versus a more dapple kind of irregular looking melanoma. This one was interesting. When I first saw this, I was sure it was a chalazion. It was a little weird that it was presenting upward instead of outward, but weird things happen. As I cut into it, treating it like a chalazion, it was more solid. It wasn't that typical kind of goopy stuff that comes out of there, so I decided I would just send it off for biopsy just because it looked weird. And it came back as sebaceous carcinoma. So I ended up taking this lady for, brought her back, did a pentagonal wedge resection with some margins. One margin was it was technically normal, but it was close enough, and they didn't do a certain type of analysis they're supposed to do with the these things because I wasn't sure at that time that it was sebaceous. So I ended up doing a second pentagonal wedge once we confirmed the diagnosis, and you know, I did other workup and stuff. Thankfully, didn't have to do any kind of excineration or anything. We were able to control it with just surgery. But always be on the lookout if anything looks weird, even if you're doing a chalazion. If the stuff that comes out isn't what you were expecting, just send it off. So just a few other quick things. I've only got about 5 more minutes. So fractures. I get sent a lot of fractures before they've been seen. And no one likes to get turfed stuff, but I always say if they've fallen hard enough to break their face, they've fallen hard enough to hit their eye. So if you're getting called on patients in the emergency room with a fracture, don't just look at the scan and say, hey, there's a fracture, just call plastics. Like, the eye needs to be looked at, because I've gone in the middle of the night to fix a patient with entrapment who also had an open globe, and now I'm waiting for the ophthalmologist to come fix the eye before I can go push around on the orbit and fix the bone. So you never know. You just always check. But entrapment is the only real emergency with a fracture, and it's a clinical diagnosis. So you'll see radiologists, if you go read the reports, they'll say entrapment cannot be excluded or something, or entrapment of muscle, which a lot of times just means it's a big fracture and the muscle's kind of protruding into like a medial, or like a sphenoid sinus kind of area, ethmoid sinus kind of area. But it's not really entrapped, it's just kind of in that space. But you usually see it in young kids because they have pliable bones that fracture and then come back up like a trap door. And that's, you got to go get that. And it can be subtle, so it doesn't always look like this picture where you have them look up and one side's looking up and the other side's not moving. It can present like a concussion. So if a patient's they're just not acting right, the parent says they're usually hyper and they've been just really out of it since they hurt themselves at softball practice or whatever, that's a red flag. And if there's any motility disturbance at all, you don't even have to wait for the scan. I would just go ahead and call the oculoplastics person so they can at least be getting ready and then order the scan in the meantime. But that has to be fixed immediately because those muscles get ischemic, and then you've got bigger problems. Always look at the scan. Don't just stop at the report. That a lot of times, and someone, I think maybe the neuro-ophthalmologist earlier this morning said, you know, a lot of times the radiologists don't even know what they're looking for, especially if you're not specific in your request of what you're looking for. They may totally ignore the orbit and say the brain looks fine from a trauma. So always go look, because you may pick something up that they missed. And then most of these can be monitored for at least 2 weeks. I don't like to see people back within the first couple of weeks unless there's some pressing reason to, because they're going to have a lot of swelling that could affect their motility and make you think they've got double vision when really once that swelling goes away, they're fine. And there's some recent studies that have come out that showing that even delayed repair has good outcomes. Steroids may help if there's a lot of swelling. Always coach these people to sleep with their head up for the first few nights and not to blow their nose. And then the only reason you really go in and fix these is if there's a lot of enophthalmos, or if they've got diplopia or pain in a functional field of gaze, which is really just straight ahead or looking down. You know, if they say, well, I'm fine except when I look all the way up and to the right, well, nobody really looks all the way up and to the right. They use their head to do that, not their eyes. So most of the time I just let those ride unless it's painful. I'm going to end with tearing. Always ask about whether it's true or pseudoepiphora. I don't hear that term pseudoepiphora a lot, but I use it in the clinic because, you know, true epiphora is tears running down the face, not just my eye feels wet most of the time. Even not I'm wiping my eye all the time. I always ask them, like, is it literally coming down your cheek or not? Because a lot of things can cause tearing. It's rarely ever just a nasolacrimal duct obstruction or punctal stenosis. They've almost always got blepharitis or dry eye or all three. But I always ask them, like, how often are you wiping? Is it just once a day, once every other day, or 4 times every hour? And then a good history is really crucial here, especially think about things like cancer, breast cancer in your female patients, because certain breast cancer agents can cause scarring in the lacrimal system. And then, of course, ocular surface disease. And I love the dye disappearance test, especially if they've got asymmetric tearing complaints, I tell my technicians to put a drop in, because it's usually about 5 minutes between when I'm wrapping up with the patient in front of them and I'm going into the room. And if I come in and the patient is complaining of a left-sided tearing and now they've got, you know, it's not going away on that side, that tells me almost without even having to irrigate the patient that they've got an obstruction or at least decreased flow. And then this is just, I'm going a little bit over time, but I just wanted to make one quick note about what Brad said yesterday. Blepharitis is everywhere. I mean, it's so under-recognized because we see it so often, we're almost immune to it. But don't forget about that and really take time. I think education with patients is so important. I have a little sheet that I give them that tells them the exact order that I like to do things in, and why. I think if they understand why you're telling them a warm compress is going to help this condition that they can't really see, they can just feel it, that helps. And I think being able, you know, if you've got the capability of taking a picture of their lid margin and actually showing them that you can see all the little ridges of their meibomian glands and all the telangiectasia. I don't do that personally, but I know Brad does some of that kind of stuff, and it really helps drive home the fact that there's an actual problem here that needs to be treated. So don't forget about that, and also don't forget about the environmental stuff and omega-3s and diet. That's really important with this too. So a couple of really good sources I just want to point out. Let's see, where is it? Right here, part 1 and part 2 from OPRS. Those are great resources that I use and refer back to a lot when you're looking up immune-related orbital problems and the proper workup for that. And then that UGOGO guidelines, you can just Google those. Now, time for questions, or everybody's ready to go get some lunch? All right. Thanks everybody for being here, and enjoy your lunch.